Good morning to all. So we have a class on emergencies resulting from substance withdrawal. So substances are illicit substances like alcohol, opioid, and others. Basically, there are three conditions are associated with the substance. One is intoxication, which you have already learned, and the second is withdrawal. And in the withdrawal, there is complicated withdrawal in certain substances. So let's start with alcohol withdrawal. So we know that in alcohol withdrawal, the two neurotransmitter system, which is dopamine and gamma aminobutyric acid, are involved, and alcohol acts through gamma aminobutyric acid. And in the long term, when the excessive and continuous amount of alcohol is there in the brain, uh, there is upregulation of GABA receptors, and these GABA receptors are inhibitory receptors. And if one tries to abstain from the alcohol, uh, there is a biochemical reactions because of these changes in the neurotransmitter system. We will see further in the slides. So in terms of symptoms, alcohol withdrawal has mild, severe and complicated withdrawal. The mild symptoms will be moderate tremors, anxiety, night sweats, restlessness, irritability, nightmares. In severe symptoms, one can have seizure, severe tremors, increased heart rate, fever, nausea, vomiting, even hallucinations, and increased agitation. In complicated withdrawal, there are three terms known as delirium tremens, Wernicke's encephalopathy, and Korsakoff psychosis or Korsakoff syndrome. So there is a timeline to occurrence of the certain sets of symptoms, and usually it starts after 6 to 8 hours of the abstinence or quitting the substance, and it may last for 7 days in uh, mild to moderate withdrawal, and severe or complicated withdrawal may last longer, more than 7 days. The first symptoms you will observe after 6 to 12 hours are anxiety, difficulty concentrating, palpitations, problem in sleeping, mood swings, nausea, vomiting, hypertension, increased heart rate, and increased body temperature. In 12 to 48 hours, there may be headache, body aches, continued trouble in sleeping, anxiety, sweating, strong craving of substance, lightheadedness, fever, irritability, acidity, and confusion. This 48 to 72 hours is the peak of the withdrawal, in which one can have seizure, delirium tremens, and other complications. May or may not have complicated withdrawal. It depends on the duration of the dependence, the amount the person consuming daily, and other medical conditions. And this can last up to 5 days or more days. It is important to create a plan so that these can be prevented or avoided. The last is 3 to 7 days, in which the withdrawal symptoms are now decreasing, and gradually the patient has started feeling relief, and but may still experience anxiety, trouble sleeping, racing thoughts, mental fatigue, and craving. So this is the timeline, and there is a term is known as protracted withdrawal, which may last up to 1 month or few months, which may be taken care of after detoxification in the relapse prevention phase. So lab tests required are CBC. So normal routine blood tests are required, and CBC like CBC, blood sugar, liver function test, kidney function test, lipid profile, routine microscopy of urine, gamma glutamyl transferase, which is more specific to the liver pathology, serum lipase and amylase for uh, if the person is having comorbid pancreatitis, ultrasound abdomen or fibroscan to see the structural change in the liver. In treatment, more or less all the guidelines says first line treatment are benzodiazepines, second line treatment is carbamazepine, and thiamine is added to prevent Wernicke's course of encephalopathy. We will discuss it later. What is the role of thiamine? Alpha 2 adrenergic agonist and beta blocker in association with benzodiazepine in severe autonomic hyperactivity. The central autonomic hyperactivity can be controlled by the drug like clonidine and propranolol. To start with detoxification, we have first choice of drug are benzodiazepine, and we are discussing here three molecules. One is diazepam, second is lorazepam, and then chlordiazepoxide. So there are two types of regime. One is fixed dose combination, and another is flexible dose combination. Flexible dose combination usually practiced in the indoor setup where patient is admitted in the ward or in other medical setup, and fixed dose combination usually required for OPD patients and the patients in at community level. So for mild withdrawal, 5 to 10 milligram of uh, diazepam is needed for few days, like 1 to 3 days uh, is required in the milder withdrawal, and lorazepam is 1 to 2 milligram orally every 4 to 6 hours as needed for 1 to 3 days. So this SOS basis, milder withdrawals are not so cumbersome, is not so uncomfortable to the patient, so they can bear these withdrawal. Chlordiazepam epoxide also in low dose for few days may be required. For moderate withdrawal, the diazepam is required in dose of 15 to 20 mg 4 times a day. Then uh, after 1 day, on the second day, it can be reduced every day in certain amount, like 10 to 20 milligram QID on second day, 5 to 15 milligram TDS on third day, and if it is 15 milligram TDS, then uh, on day 4 this can be reduced to 10 milligram QID and then 5 milligram QID. Then one can stop after day 5 or as and when needed as per the withdrawal symptoms. In severe withdrawal, 10 to 25 milligram orally is needed every hour, uh, every hour while awake until sedation is occur. Severe withdrawal can lead to delirium tremens, so higher doses are required. For lorazepam, in moderate case, 2 to 4 milligram QID, then day 3 to 4 reduce gradually to 1 to 2 milligram QID, and day 5 1 milligram BD. Then so the protocol is for all the things, all the molecules is start with higher dose and day by day reduce the certain amount of doses every day. For example, 25 to 30, 33% of doses is reduced every day as required. This is a chart for drug dose conversion when uh, diazepam is not available, then the dose conversion chart can be used to use other molecule for substitution. Uh, like dose conversion of 60 milligram of diazepam is 6 milligram of alprazolam, 150 milligram of chlordiazepoxide, 24 for clonazepam, 90 flunarizepam, 240 helazepam, 12 is lorazepam, and 64 oxazepam. So widely or commonly available molecule which we use in our clinical practice is chlordiazepoxide and lorazepam more. Oxazepam is also available, but used in lesser amount. Clonazepam is available, but higher number of tablets is required so that the person has some discomfort to taking so much of tablets. So clonazepam is not used. Clonazepam basically used uh, as anti-anxiety in psychiatric illnesses. So this is the benzodiazepine tapering regime. If the patient is on 60 milligram of diazepam, so the doses can be reduced every 3 to 4 days, every 3 days. In if you see this, this will be seems to be complicated, but by and large, you can see that after third day it is reduced by 33% for 3 days, then again 25% for further 3 days, then 33%, then 50%, then stop. So this is the broader guideline, the percentage, and it depends on the molecule to molecule. One have to convert the equivalent dose to the benzodiazepine for tapering the benzodiazepine. Now this is one of the complication of severe alcohol withdrawal, and the cause is downregulation of GABA aminobutyric acid. You know that the benzodiazepines are anticonvulsants also. So if the anticonvulsant is suddenly stopped or removed, then one can have seizure. So it is likely with the alcohol also. If alcohol is stopped, then there may be chance of developing seizure in this case. And this is also because of increasing the expression of NMDA receptors. So CNS comes into hyperexcitable state after quitting the substance, and it may occur after 6 to 48 hours of abstinence. So primary medication for controlling the seizure is benzodiazepine. The first drug of choice is benzodiazepine like diazepam and lorazepam. And for long-term therapy, phenobarbital and gabapentin can be used for stable brain activity. So the protocol for controlling a seizure is similar to that any kind of seizure you will be controlling in your emergency department. So I think the first drug of choice to control the seizure is lorazepam itself. Delirium tremens. So delirium is a term used for clouding of consciousness, fluctuating level of consciousness, and certain set of symptoms are also there which constitutes a delirium. Delirium tremens means the delirium which occurs in severe alcohol withdrawal. Simply, the feature of delirium in any other delirium because of the other physical reason are more or less same, and this is because of the severe alcohol withdrawal and characterized by rapid onset of fluctuating course of uh, consciousness with disturbance in level of consciousness. Usually occurs after 48 to 72 hours, usual duration of 3 to 4 days, but might last for even longer for 8 days. So there is a downregulation of GABA aminobutyric acid and upregulation of NMDA receptor neurotransmitter, which can cause this delirium like or delirious state. So delirium is always a disturbance of consciousness, and disturbance of consciousness is always delirium if the patient is not unconscious. The features are it is acute in onset, disorientation to time, place, and person is there. There will be fluctuating picture. In between the patient will looks fine, and in another few hours the patient found in the agitated or delirious state. Inattention is the one of the feature. Patient is not able to give attention. Reduced ability to focus, sustain, or shift attention is also there. Disorganized thinking, psychomotor changes may be hyperactive or hypoactive. Altered sleep-wake cycle or circadian reversal may be seen. The patient used to awake in the night and sleeping in the daytime. Perceptual disturbance like hallucinations are also common. The common hallucinations are Lilliputian hallucinations and and tactile hallucinations of small creature may be found in delirious state. Nocturnal worsening of symptoms is the feature of delirium when the stimulus is reduced because of the night time. The worsening may be there. Autonomic hyperactivity may also be there. So now coming to Wernicke's-Korsakoff syndrome. Wernicke's-Korsakoff syndrome may occur due to severe lack of thiamine because of the malnutrition. So Wernicke's encephalopathy is a sudden and severe acute brain disorder, and Korsakoff syndrome is a long-term memory disorder. So etiology of Wernicke's-Korsakoff syndrome is thiamine is the coenzyme which is required in the Krebs cycle and the pentose phosphate pathway, which functions in carbohydrate metabolism as coenzyme and in the decarboxylation of pyruvic acid and alpha ketoglutarate acid. When thiamine is not there, the biochemical reaction does not occur as it has to be. Then pyruvate and alpha ketoglutarate is accumulated in neuron and blood and may damage the neuronal cells. When this is severe and if this cannot be reversed or is settled as a permanent condition, this can be said as alcohol induced dementia. The symptoms of Wernicke's encephalopathy can be remembered by GOA, GOA, global confusion, oculopathies, and ataxia. In Korsakoff syndrome, there is a severe memory loss, inability to form new memory if added upon to the symptoms of GOA. The Korsakoff syndrome is consequence of Wernicke's encephalopathy. The other symptoms are loss of coordination, confabulation, confusion, delirium, which is already set in before onset of Korsakoff syndrome, drowsiness, tachycardia, hypotension, hypothermia, eye issues like double vision, drooping eyelid, ptosis may also be found in WE syndrome. In Korsakoff syndrome, the symptoms include amnesia is the peculiar feature of Korsakoff syndrome in addition to uh, GOA symptoms. Behavioral changes like agitation, anger, confabulation. Confabulation means if the person is not able to uh, remember the things of a certain period of time, they try to fill that gap with new or fabricated memory. This is confabulation. Delirium, disorientation is there, fatigue, lethargy, hallucinations may be there, lack of focus, attention, and unsteady gait. Lab tests which are required, these two conditions should be treated aggressively in the ICU. So arterial blood gas as per the requirement, complete blood count, toxicology screening if there is a doubt of having substance history. Imaging can be required like CT scan, MRI, and electrocardiogram for cardiac changes. So what is the treatment when it is expected that the person may develop Korsakoff syndrome? The person is lean and thin, cachexic, or having poor nutrition, is dehydrated. So certain point can say the person can develop Korsakoff syndrome or Wernicke's encephalopathy. Then prophylactic thiamine in doses of 200 to 300 milligram per day for 5 days, IV or oral can be given. The total is around 1000 to 1500. This is the prophylactic treatment. If the patient has developed already the syndrome, then corrective treatment is required, which means 500 milligram thiamine to be infused at least 3 times a day for 5 days along with the injection multivitamin. Multivitamin because of the other uh, nutritional deficiency because of the alcohol use. In corrective treatment, one thing should be noted, intravenous dextrose should not be given uh, when these syndromes are developed, because if you provide it with the dextrose and the brain is not able to utilize the dextrose in absence of thiamine, then there is a more accumulation of pyruvate and alpha ketogluteric acid. Isotonic saline is useful. Isotonic saline can be used, and dextrose should be safely administered once the patient has received the replacement thiamine if it is required or needed. In summary, withdrawal starts after 8 hours. Complication starts usually after 48 to 72 hours. Complication may prove fatal, must be treated in ICU aggressively. Benzodiazepines are the mainstay of the treatment. Higher doses are required in complication for longer period. Don't forget to give thiamine in appropriate doses. Don't give dextrose in thiamine depleted state. Now coming to the opioids withdrawal, you will understand the neurobiological basis of dependence and withdrawal. You can see in the picture, there is a neuronal cell wall, and on the top of it there is mu receptor, and inside the cell there is a converting enzyme ATP, which convert to cyclic AMP. So when the normal opioids are active, then this is the normal biochemical reaction. Uh, Adequate amount of ATP is uh, and adequate amount of cyclic adenosine monophosphate are there, and which in turn triggers the release of norepinephrine. So the final resultant is the release of norepinephrine, noradrenaline, or same. What happens when opioid attached to the mu receptor, external opioid, the substance attached to the mu receptor, it reduces the availability of cyclic AMP because of the continuous blockage and continuous use of the opioid. And when this opioid dependence or occupancy of opioid to the mu receptor is prolonged, then ATP started generating itself in the more amount to compensate the amount of cyclic AMP which is produced naturally. In the last, when the person is tries to discontinue the substance, or in the abstinent state, in the initial phase, the more than the required ATP is there because of the substance abuse, and when mu receptor is freed up, then these excessive amount of ATP started producing more amount of cyclic AMP and leading to excessive release of norepinephrine. And the patient experiences the withdrawal symptoms like jitteriness, anxiety, muscle cramps, rhinorrhea, diarrhea, muscle pain, and all. So in pharmacology of opioid dependence, we have opioid agonist, partial agonist, opioid antagonist, and non-opioid drugs. Opioid agonists are used for uh, replacement therapy like morphine, dihydrocodone, oxycodone, hydrocodone, and fentanyl. These are the opioid agonists which may be used by the person for dependence. Partial agonists are buprenorphine, and tramadol is a more complex drug which is low potency mu agonist and partial agonist. Opioid antagonists, naltrexone and naloxone are there, and non-opioid drugs like alpha-2 adrenergic agonist is also available. We will see further how these drugs are used in withdrawal state. The withdrawal symptoms are pupillary dilation, diarrhea, rhinorrhea, sweating, lacrimation, insomnia, yawning, muscular and abdominal pain, restlessness, and craving. In addition, there may be autonomic excitability, which is seen as tachycardia, hypertension, piloerection, shivering, low mood, irritability, and anxiety. So what are the molecules which are available for substitution therapy for treatment of opioid withdrawals are methadone, buprenorphine, tramadol, and tapentadol. Other molecules are also available, but in our practice here we used to use uh, buprenorphine, tramadol, and tapentadol, which is easily available. So the mechanism is, you can see that the blue part on the cell wall is mu receptor. Uh, when the patient is dependent on substance, these receptors are occupied with those substance, and if it is If the person is try to quit it without the help of the other drug, it will lead to severe withdrawal. So to reduce or curb the severe withdrawal, this can be replaced by the drugs which are buprenorphine, methadone and tramadol. So mu receptor is occupied by these drugs, and alpha 2 adrenergic receptor take care of the norepinephrine release in autonomic symptoms. The drugs which can be used in alpha 2 adrenergic receptors are clonidine, lofexidine and tizanidine. What are the doses to detoxify the opioid dependence? If you are using buprenorphine, begin when the withdrawal symptoms emerge. So day 1, 2 to 4 milligram every hour for 4 hours. The total of 8 to 12 milligram of dose is required for day 1. On day 2, 60 milligram in divided doses, like 8 milligram twice daily. And from day 3 to 9, decrease by 2 to 4 milligram per day as tolerated. Add clonidine 0.5 milligram every 4 to 6 hours for breakthrough symptoms of autonomic hyperactivity. While giving the clonidine to reduce the hyperactivity, autonomic hyperactivity, one should keep in mind that clonidine is also a central antihypertensive. To take care of the hypertension of the patient, it should be monitored with this drug, and basically the symptoms are peak at second to third day, and by third day you may started decreasing those as per the guidelines. Methadone to begin with on day 1 with 10 milligram, increase by 10 milligram every 6 to 8 hours for maximum dose of 40. And then for second day there are two options. Day in option 1, day 2 to 4 decrease by 10 milligram each day, and day 5 to 8 decrease by 2 milligram each day. Option 2 is day 2 to 8 decrease by 5 milligram each day. So basically one have to gradually decrease the doses so that the body can slowly adjust to the previous state of uh, biochemical homeostasis. Clonidine is, if required, then on day 1 it may be given in the 0.1 to 0.2 milligram every 4 to 6 hours with maximum dose of 1.2 milligram. Day 2 onward taper by 1.1 to 0.2 milligram per day. Lofexidine, day 1 0.5 to 0.7 milligram every 6 hours. On day 2 and onwards, decrease each dose by the zero point 0.2 milligram every 1 to 2 days. Now, after controlling the mu receptor and the alpha adrenergic receptors, some other drugs are may also be required, are ancillary drugs, like for anxiety clonazepam may be used. For muscle cramps, ibuprofen uh, can be used. For nausea, vomiting and diarrhea, ondansetron, prochlorperazine can be used for nausea, vomiting and diarrhea. For sleep, additional trazodone and zolpidem may be required. So it is the symptom based approach, and treatment is a process in the case of withdrawal of any drug. Now coming to the cannabis use disorder, which is also common substance use disorder in this geographical area. So we all know that exogenous cannabis, which has tetrahydrocannabinol, acts on the endogenous cannabinoid system in the brain by binding the receptor CV1 and CV2. So CV1 receptor are located primarily in presynaptic neuron of the CNS and are responsible for acute psychological and cardiovascular effect. And CV2 receptor is located in the periphery and modulate immune function and inflammatory responses. So CV1 is particularly for the CNS. In withdrawal syndrome of cannabis, the symptoms are anxiety, irritability, depressed mood, restlessness, disturbed sleep, GI symptoms, and decreased appetite. And most symptoms begin during the first week of abstinence and resolve after few weeks. The drugs which can be helpful in cannabis withdrawal, there is no particular antidote for this, uh, but the drugs which are studied and shown the results and which will be discussed here is the bupropion and divalproex worsens the withdrawal. It should be avoided. Fluoxetine reduce the cannabis use, should be used for relapse prevention. Nefazodone improves anxiety during the withdrawal. Lofexidine with tetrahydrocannabinol reduces the withdrawal symptoms. Cannabis agents like oral THC, oral tetrahydrocannabinol capsules reduces the withdrawal. Dronabinol has mixed result, and the cannabis antagonist is known as rimonabant attenuated the effect of cannabis in later maintenance state. So rimonabant can be used in relapse prevention as blocking agent. In summary, symptomatic treatment is the mainstay. Rimonabant may prove useful. Withdrawal lasts for days to weeks. Various drugs like oral THC, lofexidine, rimonabant can be used to attenuate withdrawal. For long-term abstinence, fluoxetine and rimonabant can be used for relapse prevention. Now, sedative, hypnotic, and anxiolytics means benzodiazepines. So we have discussed the tapering of benzodiazepine in alcohol withdrawal part in this session. So same protocol is used for sedative, hypnotic, and anxiolytic. You have to calculate the equivalent dose as per the diazepam and to make a protocol to gradually taper down the doses of substituted benzodiazepine. Withdrawal of stimulants. So there are no reliable, effective, specific pharmacological treatment is available for stimulants. Supportive care is the mainstay. Unlike withdrawal syndrome described for alcohol, benzodiazepine, barbiturate, stimulant withdrawal is generally milder, self-limited, and not typically associated with delirium or other medical complications. So supportive and conservative care is mainstay. For cocaine, to date, there is no approved medication to treat cocaine use disorder is available. Trials of direct dopamine agonist, which increases presynaptic dopamine release, has also not shown benefit in these patients. Dextroamphetamine has a mixed result. The atypical psychostimulants modafinil has shown little benefit, and that cannot be generalized. A sustained release formulation of methylphenidate did show benefit in one study. Opioid antagonists like naltrexone and typical and atypical antipsychotics and the D1 receptor antagonist ecopipam have all been investigated and none have shown clear evidence of benefit against the placebo. Disulfiram also appears to have a more direct pharmacological effect on the metabolism of dopamine and cocaine itself and found helpful. Baclofen, tiagabine, modafinil, which likely affects the GABA and glutamate neurotransmissions, have failed to show any benefit. So, the symptoms of caffeine detoxification of caffeine, the symptoms of caffeine withdrawal typically resolve with the ingestion of dose of caffeine. The person with provisional diagnosis of caffeine withdrawal more than 2 weeks should be carefully rehabilitated for another diagnosis. Headache may be taken care of by aspirin and other analgesics. If caffeine withdrawal occurs because a person is attempting to abruptly stop the caffeine use, advise the patient to taper caffeine consumption over the period of time. So no specific antidote is available for caffeine also. So gradual reduction of caffeine consumption can be done in the control environment also and can be advised to the patient on OPD basis. Now hallucinogens. What are hallucinogens? The molecule like LSD, PCP, ketamine, psilocybin, mescaline are the hallucinogens. In withdrawal symptoms, there is no recognized set of symptoms. There is no recognized syndrome of withdrawal of hallucinogens in the humans. Supportive treatment again is the mainstay for hallucinogen withdrawal. The efficacy of psychosocial treatment afterwards the detoxification that have empirical support for the treatment of other substance use disorder is unknown in the case of hallucinogen use disorders. So there are scarce data for these. For volatile substance detoxification, case studies show that in reducing craving, aripiprazole and lamotrigine are useful. For withdrawal symptoms, baclofen is useful. Neuropsychiatric symptoms can be taken care of by carbamazepine, haloperidol, and risperidone. Behavioral symptoms such as increased locomotor activity can be controlled by vigabatrin. So again, the treatment is supportive. No particular antidote is available for volatile substance. In the last, there is nicotine withdrawal. In nicotine withdrawal, although won't come in the emergency for their withdrawal symptoms, but one can have idea how to detoxify the person who is consuming nicotine. So basically, it's a OPD procedure in which what is required is to set a quit date. The patient has to set a quit date, and on that date, he has to stop the substance abruptly. And some patient seizes it abruptly, but some are required to quit the substance in a gradual manner. So brief advice should be focused uh, on the need of medication, group therapy, weight gain concerns, high risk situations, making cigarette unavailable, and so forth should be discussed with the patient in the detoxification of or de-addiction of nicotine dependence. Follow-up should be with the shorter period of time like 2 to 3 days because relapse is often rapid and quick in the nicotine withdrawal. The available modalities which are used for replacement for nicotine are nicotine gum, nicotine patches, microtabs, lozenges, inhalers, and nasal sprays. In our setup, the gum, lozenges, and patches are widely available or and can be used. Non-nicotine medication which are useful in tobacco dependence are bupropion is said to reduce the craving and it can be given for 6 to 12 weeks or more. The doses are 150 to 300 milligram. Again, the clonidine reduces the sympathetic activity in the locus coeruleus. Nicotine vaccines are there in under development. Uh, currently it is not available, but it's a good hope for the nicotine dependent patient in the future. When it is available, this will be a good choice. Another drug for nicotine dependence is varenicline. Varenicline is cholinomimetic drug, or you can say it is a blocking agent. So for day 1 to 3, 0.5 milligram orally once a day is required, and from day 4 to 7, 0.5 milligram orally 2 times a day, and by the 8th day 1 milligram orally 2 times a day. The duration of therapy is 12 weeks. So it's a blocking agent. It is required in the period of relapse prevention when there is propensity to slip to the substance. So one can give this. The role of this varenicline is when the varenicline is in the body, it will acquire the cholinomimetic receptors, the nicotinic receptors, and if the patient tries to smoke or chew the tobacco, he will not get that effect what he was having before the uh, detoxification. So thank you. So we had discussed about the alcohol withdrawal, opioid withdrawal, cannabis withdrawal, other substance like volatile substance, hallucinogens, caffeine and nicotine withdrawal symptoms and how they can be treated. So hopefully this would be a good and informative lecture for you, and you are in the position to deal with this patient efficiently. No? So thanks to you.